Well, good morning, or at least it's morning here in London. And first of all, thank you very much for inviting me to contribute to your conference. I'm sorry I can't be there in person, but I hope my contribution today will be some help to your overall discussion. I'm going to speak about aspects of stigma and discrimination. I'm going to focus on aspects important in clinical settings, but also tell you something about the emerging findings from our new National Anti-Stigma and Discrimination Programme in England. Let's first take stock about the severity or the magnitude of the issues we're talking about. In the second slide, you can see Tom, and he says the issue of stigma against mental illness sometimes feels like the worst part about it. So for many people, the primary impairment of the mental disorder is difficult enough, but the secondary elements about the reactions of others, in fact, present a greater difficulty in people's everyday lives. So next slide, I want to do three things in this talk. First, I want to summarize some evidence that stigma and discrimination commonly affect some people with mental illness. Second, I want to talk about some of the richness of experience about how these things affect people from the point of view of service users, of consumers. And third, I want to give you some emerging evidence, particularly from my own country, about how anti-stigma interventions are possible and now are beginning in several countries. First then about the nature of these phenomena. And I'm going to refer in this talk to quite a lot of material from this book called Shunned, which is really an overview both of stigmatization and of the forces of discrimination as they have an impact in this domain. So I like to simplify things into a rule of three. And for me, it makes sense to think of stigma as comprised of three particular challenges. The first problem is one of knowledge, namely that most people in our populations have limited knowledge about mental illness, and much of that knowledge is wrong. So it's both ignorance and misinformation. The second challenge is one of the affective element of our emotions, our feelings, where the limited evidence suggests that overwhelmingly, in general populations, feelings are negative towards people with mental illness. And the third domain is the behavioural one, namely discrimination. What in fact are the ways that people with mental illnesses are excluded, for example, excluded from proper clinical care by virtue of the forces of stigmatisation and discrimination? Now, I'll go through a few of the domains in which stigmatisation appears to be powerful for some people, starting with discrimination at home. We know that often in the early stages of a condition, family members, for example, parents of a young person, won't really know how to understand changes. Perhaps the person's lying in bed, not going to college, and will often resort to moral explanations. You're lazy, you're weak. After the confirmation of a diagnosis, then other forces come into play, particularly negative reactions, not just to the individual, but also to the nuclear family members, so-called stigma by association. And we also know there are other impacts on home life, for example, higher rates of homelessness. The second domain relates to discrimination in friendships, intimate relationships, and childcare. And here I found after already over 20 years as a psychiatrist, the data we found from this research has really surprised me. How commonly, among young people developing a mental illness, many and sometimes all their friends disappear. Quite often spouses and partners, husband and wives disappear as well, not just because of the behavioural difficulties, but because the very idea of being with somebody with a mental illness is unbearable. And there are a number of consequences of this, for example, impairments in sexual relationships. The third domain relates to work, and of course in many countries, certainly mine, the health service is one of the major employers across all the economic sector. And we know, mostly from literature, or from literature from governmental bodies and non-governmental bodies, not peer-reviewed literature, that if you are known to have a mental illness or have had a mental illness, then there are a number of damaging consequences. For example, you may be less likely to get a job, more likely to be sacked, your pay and your promotion prospects are also impaired. And this leads at the moment to a no-win situation, a dilemma about whether to disclose or to conceal your condition. And still we have relatively little understanding about the detailed processes of that so-called conflict judgment situation, and also how best to help people who want to seek work and who are genuinely unsure about how much to say and to whom and when, for example, in an employment application process. I mentioned a little earlier about the extent of ignorance in many of our populations. Here's some example. This is a survey carried out by a charity in Britain called the Shaw Trust, who interviewed 500 bosses of companies across the country. We can see here one of the questions. The question was, what percentage of employees do you think will have a mental health problem at some point during their working life? Now we know from epidemiological surveys that this is probably at least 35–40%, perhaps higher, of adults at some time in their lifetime who will develop an episode of mental illness. In fact, almost a half of the employers said we have nobody in our organisation, not only who doesn't have a mental illness now, but who ever will have a mental illness in their working lifetime. So this gives an indication about the extent of lack of knowledge about the frequency, the commonness of mental disorders. Now, we've done a series of surveys in this country following up upon that initial baseline survey of employers. This is one recent paper published last year where we described in more detail the nature of their responses. And certainly until 2006, not only was there ignorance about the occurrence of mental illness, but employers showed very little knowledge about what could be called reasonable adjustments or reasonable accommodations that anybody with a disability should be entitled to, including people with a mental illness-related disability. The fourth area refers to the media, and to summarise, now very strong evidence that much of media coverage is downright discriminatory and derogatory, especially, interestingly, in children's cartoons and animations. And still, in many countries where this has been assessed, relatively few direct contributions or direct quotations by people with a mental illness. This is an example from The Sun. This is the most widely read newspaper in my own country. And interestingly, we have something called the Press Complaints Commission, which is the judge of what can be put in newspapers or what shouldn't be printed and distributed. And they have said that the word schizos, in plural, should not be used in newspapers. But they have judged that the word schizo, as used here, is fair to use as a descriptor for an individual person. And we're now fighting this to try to push back that particular instance of discrimination. I want to say in a bit more detail about the aspects of physical health care which show clear patterns of negative discrimination against people with mental illness. By way of background, you may know that until recently it was understood that people with mental illness may have a life expectancy 10 or 15 years less than their counterparts in the general population who do not have mental illness. More recent data, in fact, is worse. The most recent findings across 3 Scandinavian countries show that for schizophrenia, affective disorders, bipolar included, drug and alcohol misuse, in fact, the gap between the general population life expectancy and for people with mental illness is 20 years. And that's even in Scandinavia with an excellent health system. So we see third world death rates in first world populations among people with mental illness. And one of the reasons for this is the concept of so-called diagnostic overshadowing. So for physical health care, it's now well established that people who are known to have a mental illness and who present to physical health care services on average get worse physical health care. And we can see that there have been several studies, particularly by the Yale group led by Druss, to give solid data behind that proposition. For example, in this study of people with heart attacks, with myocardial infarctions, you can see that on average, people who also had a mental illness were investigated less, treated less invasively, and had higher death rates adjusting for all other risk factors. Now, there are other domains in which it's becoming clear that there are differential patterns to the disadvantage of mentally ill people, for example, in relation to cancer. And this is a review paper we did last year in Lancet Oncology, specifying a lot of the ways in which the care is structurally worse. And one of the things I think is important for professionals, healthcare professionals especially, to reflect upon is what part we have either in initiating or in perpetuating those patterns. And specifically, for psychiatrists or other mental health professionals, what should we do about this? So I'd want to draw to your attention here a paper from a journal called Advances in Psychiatric Treatment from last year, which I wrote with a colleague here, Dr. Diana Rose, who's the head of our consumer research team called Service User Research Enterprise. And what we suggested is that there are a number of areas which need further detailed examination to change and to improve practice. For example, how we might not just give, but offer or negotiate a diagnosis, trying to understand what it means to an individual to be told, for example, you have schizophrenia. And do we as professionals understand the meaning that is understood by the recipients of that, which may be quite different from our intended message. For example, also giving structured packages of information and support and interpretation to family members, especially for the more stigmatized against diagnostic labels. Also playing a part, and it seems to me as a profession we do have a wider duty of care for the population, not just to individuals who happen to be affected at one particular time, a wider duty to the public to explain what we're doing and also what these labels and diagnostic terms mean, to make them more familiar and less stigmatizing. And I think another part of what we might want to do, working closely with patients and with service users, is actually to go into situations to support them in preparing for job applications. Now, it may not be the doctor who does this, it may be a vocational worker, but as the team as a whole might well want to take this seriously and actually do preparations of resumes and curriculum vitae, mock interviews for, where one might disclose or not disclose mental illness, for example, and prepare the person in a great deal of detail for critical points such as job applications, which either are a point of opening a door or closing a door to more social participation and economic prospects. For those of you interested in the question about giving diagnoses, again, I did a review paper last year with my colleague Dr. Rose, which is published here in the next slide in a journal called EPS. Now, it seems to me that we may well want to organise our services in a way designed to try to minimise stigmatisation. For example, by initiating and supporting developing supported work schemes. For example, by supporting psychological treatments designed to improve empowerment and self-esteem so that individuals doubting if they should even apply for a job can be given the confidence to do so. So on one hand, it's empowering individuals to apply, for example, for a job. On the other hand, we're working with potential employers so that the two together come both with the esteem to apply and with a lack of discriminating practice into a fair assessment of an individual's application for a particular post on the balance of their skills and abilities. Now, I know at this conference Professor Corrigan is going to talk about structural or systematic discrimination, so I just want to say a brief word about this. One instance is where there may be extra funds to invest, and are they spent proportionately for mental health compared with physical health? In my own case, in this country now, it's the inverse, which is when there is disinvestment, cuts, for example, in our health service to the order of 10% magnitude. Are they taken fairly and proportionately from mental health, or is that cut to a greater extent? So in the second part of this talk, I want to say something about the experience of discrimination from the point of view of patients. And particularly on the next slide, at the Indigo study, I want to introduce you to this worldwide network, now with 40 countries collaborating, to try to understand the nature and impact of discrimination. In the first study, where I want to give credit to my colleagues Norman Sartorius and Diana Rose and colleagues, we went and talked to people in 28 countries, people with schizophrenia. And to do this, first of all, we had to develop a scale. The scale is now called DISC, Discrimination and Stigma Scale, to assess these experiences. So let's get straight to some of the results. you can see here that the top problem, rated by over 700 people with schizophrenia in 28 countries, was the diagnosis itself. Fully a half said this was a problem for them trying to manage their condition. And then you'll see about a half had a problem with making friends, about a third in occupation, either getting a job or keeping a job. We also want to look at international patterns to see if there were any countries clearly more or less stigmatizing, and indicated here with the arrow is Canada. And you can see across these 32 domains relatively similar pattern about the extent of stigmatization. Now, an additional concept that we developed while running with this line of inquiry is what's sometimes called internalized stigma or self-stigma, which we've described as anticipated discrimination. For example, a person who does not apply for a job because they fully expect to fail, even if they've never applied and never failed before, since developing a mental illness. And we found that this is actually quite common. You can see that 2/3 of these hundreds of people across so many countries did stop themselves from applying for a job, and also over a half had stopped themselves initiating a potentially closer intimate relationship. So we shouldn't minimize the extent to which people with conditions such as schizophrenia actively inhibit themselves from trying to take part in wider society and social participation. And you can see here as well, on this subscale, which goes from 0 to 4, still quite similar rates. They're both common, but similar between countries. And you can see Canada slightly towards the top end of that pretty similar range across so many countries. And if you'd like to have more information about this, this was published 2 years ago now in The Lancet. So in the third and final part of this presentation, I want to say something about accumulating evidence of how we can have a beneficial effect to reduce stigma and discrimination. I won't talk today about initiatives at the local level because you've asked me to address national level interventions. Just to say that again and again it's become clear that the most active element is direct social contact in a variety of settings with people with mental illness. For example, during a talk or a teaching session or an anti-stigma program, we may have one or two consumers speaking directly to, for example, policemen or school children or journalists, and it's that direct contact that has repeatedly been shown to be the most active ingredient for stigma reduction. Coming on to the national scene then, you'll know that over the last decade there have been well-constructed programs first in New Zealand and then Australia, more recently in Scotland, England, Canada, and now also other European countries, designed at the national level to aim to reduce stigma and discrimination. And you may have come across one of the sporting heroes of New Zealand, for example, John Kirwan, who was their rugby union national team captain, who caused a sensation by disclosing on television in an advertisement that he had had a period of anxiety and depression. And you can see on the slide here, over 3/4 of adults in New Zealand saw that particular advertisement, and 98% said that they responded positively because of his openness and courage in speaking about this difficulty. Well, that's all very well, but does it actually have any effect? You can see here serial national attitude surveys in New Zealand over 4 years. And here are 3 indicator items of the questionnaires used. People are now more accepting of mental illness. People with mental illness can still lead a normal life, and mental illness can happen to anyone. And in all the cases, you see an increase. All of these are significant increases over the time period. So at the least we can say is that the pessimist who might say stigma can't be changed, it's intrinsic, somehow it's to do with tribal in-group, in-group, out-group, us, the other, those ideas are wrong. We can see both positive changes here, and in some studies, for example, of the last 10 years in England, some decreases as well in favourability and deterioration in social distance assessments. So let's come on to the events in the last couple of years in England. I'm really pleased to tell you that we've now got a well-funded national anti-stigma campaign called Time to Change. This is funded by 2 large charities called Big Lottery and the Comic Relief, and it's led by 2 national charities. One's called Mind the other is called Rethink. My role is to lead the team which assesses the impact of this campaign. You can see on the next slide that we've both got a lot of press coverage, indicating, for example, famous people who made a major contribution to the world in the past who've also had mental illness, such as Winston Churchill, Florence Nightingale, Charles Darwin, Abraham Lincoln. And also at the inception, this was a deliberately cross-party approach so that we weren't going to have any political divisions. Interestingly, we had the then Prime Minister supporting it, and we have the current Prime Minister also supporting the programme. Now, from the results of the first year, although we saw a lot of market penetration with the advertising materials, the impact was lesser upon what we call black and minority ethnic groups. So in the second year, you can see here Frank Bruno was one of the champions, and he is the former world heavyweight boxing champion. We also had another lead celebrity called Trish Goddard, who's a sort of Oprah Winfrey of the British world, also a black woman, deliberately to give more salience to get the message out to black populations within England. So there's not time today to go into all the detail, and if anybody wants to contact me, we'd be happy to send greater detail to you. But to give you a sense of the overall programme, there are both national and local level elements. The national includes use of television, filmed in cinema advertisements, radio, a lot of newspaper contributions, and also a series of local programmes run by local charitable groups aimed to get to particular target audiences, for example, teaching students, for example, medical students. And there's another layer of many local projects giving empowerment skills to people with mental health problems so they can directly contribute to, and where necessary, challenge the media. Now, in the course of doing this, we've had to do quite a lot of methodological development. I mentioned a bit earlier the new scale called DISC, which we developed to assess discrimination because we didn't have a scale particularly for that purpose. We also, oddly enough, found that there wasn't a scale that was right for us to assess the knowledge of any whole population or subgroup about mental illness, so we've just developed such a scale called the MAX, and that was published last year in the Canadian Journal of Psychiatry. Now, I mentioned one particular target group that's especially important, namely employers, and we've just done the first follow-up of this national survey. You'll recall there are 500 employers, and we then go back and assess again any changes. This is published this year in the journal called EPS. And you can see here some of the early changes. The black columns show the data in 2006, that's baseline, before the national programme. The hatched columns show the first year follow-up. This is the first time we've assessed bosses' attitudes, employers' attitudes since the programme began. And what we want is a shift to the right. We want employers to say, yes, we do realise that mental illnesses are quite common. We see that quite clearly. For me, this is a surprisingly rapid change in the knowledge of employers. Another whole element to the assessment of this programme is to try to get into discrimination behaviour change. And one way we're doing that is to take the DISC, the so-called discrimination scale, and every year we phone up 1,000 people across England, people who have severe mental illnesses and are receiving specialist mental health care. And we say, in the last year, have you experienced discrimination in any of these domains? You can see here in the blue columns the baseline data. And you can see in the red the first year's follow-up data. So in this case, what we want is the movement to go to the left. We want people to report experiencing fewer domains of discrimination than they did in the baseline assessment. And again, to my surprise, we can see that. We've got a significant movement of a lower average number of areas of discrimination in just the first year. Now, I'd be wrong to suggest to you that this change could all be attributed to this first phase of a national campaign, and also it's early days. We haven't yet got the second year data in and fully analysed. But the initial indications are positive that discrimination, as well as population attitudes, as well as some segments' knowledge, such as employers, are moving in the right direction. So if we take two specifics, You can see here from this patient survey, the service user or consumer survey, two specific data points. One is discrimination in finding a job, dropped from 25 down to 16%. Second, discrimination in keeping a job, dropped from 19 to 13%. Both significant differences, but also, clearly with a health warning, it's early days, we'll have to see if this is sustained or developed further. So to summarise our national campaign in England after the first follow-up year, we've got general population surveys, we have surveys of people with mental health problems, we're also doing interventions specifically with medical students and with trainee teacher students. We're going to World Mental Health Day events, for example walks in the park, where there is a mixing and direct social contact between people with and without mental illness, then we're assessing the impact of those contacts. We're also doing an annual assessment of cuttings from newspapers, national and local newspapers. And again, we're finding that the best predictor of more favourable attitudes and more positive change is having direct contact with people with mental illness. Now here's a paradox, because in fact we all know many people with mental illness because they're so common, but we do not necessarily know that those people have mental illness because they're busy keeping it quiet. So this opens up the intriguing possibility that if disclosure could become more easy, and more people with mental illness now, or histories of mental illness, were able to talk about that, so more of us then become aware of having direct contact, and that might, at the population level, begin a virtuous cycle. So just before I finish then, here's an interesting recent phenomenon, I think. This is Serena Williams, the tennis player. You can see she's talking about having had a period of depression. This followed the death of her sister in a drive-by shooting incident in Los Angeles. And what's interesting here is that just after disclosing this, she went on to win Wimbledon and to win the Australian Open Tennis Championship. So she is demonstrating not just some degree of improving after a mental illness and getting on with your life, but the possibility of full functional recovery in a celebrity in this case. So in closing then, I've wanted to cover in this talk several themes which are given in much more detail in this book called Shunned. I wanted to say something about the evidence that stigma and discrimination do affect some, but not all people who have a mental illness. Secondly, some hint about how this is experienced from the point of view of the patient perspective. And third, I've wanted to give you indication of the early findings from our assessment of the Time to Change campaign in England, which is beginning to show positive change in the desired direction. So at the bottom here of the final slide you can see my contact details. I'd be very happy to send you more information if you'd like to follow up any aspect of this talk. Again, I apologise I'm not able to be with you in person today, but I hope your conference is a great success, and I wish you every strength in your work against stigma and discrimination. Thank you very much for your attention.